Sure.
All right. Hello, everyone, again. This is the STR webinar. Thanks for logging in. Perhaps some other folks will join. I'm going to have Travis go first this week. There you go, Travis.
All right. Somebody just joined. Let's see who, or somebody is joining.
Okay,
Another person from Augusta, looks like. All right.
good.
I'm going to show, let's see. Now, Howard, this is the, let me make sure, here, this one. Yeah, this is the one very similar to what you showed us yesterday. And this is the scout from a chest CT. This is a few years ago. Again, I was digging through the teaching file here looking for other stuff and came across this. And the history is withheld at this point, but you see that along the aorta there's this funny little, triangular-shaped area of increased attenuation, for lack of a better description on that. Don't have a great view of it on the radiograph, but I'll show you on the CT. It's kind of peculiar that you have this extremely dense stuff in the wall of the aorta, and you can see it's along the descending thoracic aorta, and it, when you window down, you can see it's very uniform in its appearance. And so this is actually intravenous contrast that's in the wall, and you can see right here in the very inferior-most image, just on the non-con, that there you may get a hint that this could be a little dissection or intramural hematoma. And sure enough, here's the post-contrast study, and you can see that this is all just it ends up being iatrogenic intravenous contrast that's in the wall of the aorta. And I'll show you the rest of his aorta here, as you'll see that he has this. Now in the infrarenal aorta, you can actually see a frank dissection flap, and it kind of communicates here within the distal infrarenal aorta, where he looks like he has more of a diseased aorta. I don't know how much of this is pre-existing within this abdominal aortic aneurysm, or how much of it is inflicted, but you can see he's got atherosclerotic disease lower down. And also notice how tortuous his vessels are too. So here you can see is the femoral sheath. And so the whole history of this is that they had attempted the catheterization, but were unable to pass the they said they very tortuous right femoral artery and aorta, so preventing the catheters from reaching the left heart. And they noted an aneurysm. They didn't really give much more detail than that, but so undoubtedly they ended up creating an iatrogenic dissection here and then running up their catheter in the wall of the aorta, which is when they injected. So this is a few days later. I think this was 2 days after the study, and you can see that the intravenous contrast is already almost completely resorbed, and there's not really much there in terms of a dissection. So I thought that was a nice intramural iatrogenic hematoma
With a test injection. A test injection.
What's that?
The volume of contrast is from a test injection. Then they realized and confirmed that things were not right.
Sure. So, and then the radiographs, you can see a little bit. Prospectively, I'd never know. I would think more that this looks almost like it's lucid in the lumen, like there were an intra-aortic balloon pump in there. Of course, you don't see one, though.
Wow.
But that scout was pretty interesting. So.
Yeah.
So iatrogenic dissections and intramural hematomas or just aortic injury, whatever. I don't know what the best term for that is, other than iatrogenesis imperfecta again. So
interesting.
This is a really cute radiograph, and Howard, this was your case that you showed me, or that you showed a couple weeks ago. I think it was the isolated left upper lobe collapse, sparing the lingula. Here's a patient. You can see he's intubated. He's got right lower lobe atelectasis at this time, maybe a little bit of left lower lobe atelectasis. And then on one of these images, here it is, the next day, now he has a really cool appearance to his right hemithorax. And this is a great one for residents because you can still see the right heart border, but you have complete right lower lobe atelectasis, and now you have a reverse S sign, or at least the upper half of it. There's no mass here, and right upper lobe collapse. So he's got combined right upper and lower lobe collapse, sparing the right middle lobe, and then of course on the next study he's reopened his right upper lobe, his right lower lobe, and now a portion of his right middle lobe are collapsed, or at least if not the entire thing. So he's just got, but this one was the first time I've seen this combination.
That is unusual.
So,
It's a great example of that. Wow.
yeah, and then whatever this is, if it's more atelectasis or if he aspirated here, I don't. Here's the CT. Yeah, it looks like he's got some more discrete central-lobular stuff in that right lower lobe. And but yeah, this was earlier, a couple days before, and you can see his right lower lobe, and then a little bit of presumably just aspiration or something going on in his right middle lobe as well. And then his right upper lobe collapsed after that. So. But yeah,
that one's really interesting. I've never seen a case of this, but I've seen it in a textbook. But if you have a sufficient amount of atelectasis involving the right upper lobe and the right middle lobe, the opacity can eventually end up producing a very strange opacity in the central portion of the lung called the elephant's ear sign. And I've never actually in my career seen an elephant's ear sign. You'd have to look up in Google or in a textbook for the elephant's ear sign, because it's really unusual to get the combination of right upper and right middle. But this one is a nice example of that.
Yeah. And right upper and right middle can more simulate left upper lobe collapse, correct? Now you don't have the aorta to give you the true Lufsigal sign, but I think I remember reading that one time. But I'd never heard the term elephant's ear. I'll look that up. I know that, or I think if I remember correctly, that Carl Furman from Pittsburgh had one of the ACR case in points probably several years ago now that was right upper and right middle lobe collapse that I distinctly remember, which I thought was cool, just seeing these different combinations.
Yeah, I want to look that one up because I think I stand to be corrected, but the elephant's ear sign is right upper and right middle combination.
Here, again, I'm saving some of these for some of my residents since we're early on in the year. I think this is a nice example of a potential blind spot on the PA radiograph, and it's slightly unusual appearance for this common entity, but you can see, or hopefully you see, that there's a weird curvilinear opacity projecting over the right hemidiaphragm. And so keep that in mind when we look at the lateral view. And here you can see again why I think the lateral in a lot of cases makes things a lot more apparent, and you can see it's more posterior and it's medial. So could be a diaphragmatic eventration, could be a pleural mass at this location. Doesn't really look like a hiatal hernia. It could be in the mediastinum as well. And so on the CT, or diaphragmatic eventration or hernia, I should say. But in the CT, you can see it's none of those. That this is a complex kind of. It's actually a bilobed, or there's at least you can see a little ear off of this thing here, and it's kind of intermediate attenuation. But what I think is also interesting on the CT and a clue to the chronicity of this is how it's remodeling the vertebral body here. You can see that this vertebral body is definitely a little scalloped, like it's been there for a while. And I wasn't, when I was looking at this, not knowing the answer, I wasn't sure if this was going to be a fibrous tumor or if it was going to be something extra pleural. And any guesses?
How far does it go into the abdomen? So it
stops. It's retrocrural.
Because I started to think of a neurogenic tumor and wondered whether it was going up from the abdomen into the chest, having arisen below the chest. Let's see.
Yeah. I would think of a neural tumor or an extralobar sequestration.
Yeah. The sequestration is a good thought too. Yeah, it turns out it was a schwannoma. So it was pretty. They had to actually resect some of the vertebral body. They're saying that it was very adherent to the portions of these vertebral bodies that it had remodeled. So this is one of those ones, if you go by strict like Felsen mediastinal classification of compartments, that it's kind of right at the transition between middle and posterior mediastinum. I guess I would argue that it's probably a little bit more than a third of the way behind the vertebral body, but it's, I just thought it was a cute case with nice radiograph findings.
Yeah, when you see things come up like that, or in that particular location, one should think of the so-called thoracoabdominal sign. like an abdominal process coming into the chest, could produce these kind of findings. So if you see it in that location on the frontal and the lateral projection, you think of processes that come from the abdomen to the chest, and there are three places. One is the medial, and the other is the lateral lumbocostal arches. But this one is really not one of those, but rather retrocrural by virtue of its location. So it's a variation of the theme, somewhat, of the thoracoabdominal sign, or it has some similarities to that.
Right.
Even though it isn't something that's primarily arising in the abdomen, for example, coming up into the chest. But things that do that can produce the same kind of thing on the frontal and lateral projection for sure. Yeah, that's really interesting.
And the intervertebral foramen was okay, right?
Yeah, yeah. The I don't. This is a pretty thick image. We didn't have coronals, but I don't think you can see any like either splaying of the ribs or enlargement of the intervertebral foramen. I looked. I didn't see anything actually arising from a nerve sheath in the chest. So
I like the way the cruise is draped over it.
yeah, right there.
Mm-hmm.
So, all right. And then this one is one I saw last week that is just, again, a really fascinating example of this. And this is one of those radiographs. The guy's not taking the largest breath you've ever seen, but I would still argue that they're very fine little nodular opacities, and they're almost miliary, but they're just tiny micronodules in predominantly the lower lobes, and you can see them better on the lateral, I think. At least that confirms that it's not just him not taking a big breath. And this was back in 2011, and there's one other finding here on the radiograph, which actually gives a clue to what this turns out to be, and it's this subtle tracheal deviation to the left with something. And it's not just a goiter that's here. And I'll show you, this is a CT from 2 years following, and so you can guess he's had a thyroidectomy at this time, so you probably guess what he has. And he has some larger nodules in the upper lobes, but just to show you how much miliary metastatic disease from thyroid cancer there is, and this was papillary thyroid cancer, and just how gravitational dependent it is. It's really quite remarkable. And the reason I saw a follow-up on him a month ago, and I'll show you the intervening radiograph too, because it's really quite a confusing pattern. And I know, like, that my colleague Brett hates when people when residents just say everything is reticulonodular, because in most cases you can tease out what's reticular and what's nodular. I would argue in this case there's nodular and maybe a combination of both. It looks like there's a little reticulation in this case, but this CT that we saw last month, I mean, this is now to the point where it's just like confluent consolidation. So, it's simulating consolidation with just the confluent metastatic disease that this patient has. But I thought the original radiograph was just a really nice example of these. I think it's a good differentiation of nodular versus reticular, just how discrete these little, some of these little foci are, especially on the lateral view. So, all from metastatic papillary thyroid cancer. So it's one of those ones, obviously, we always think about with miliary or hematogenous metastatic disease, but this is the most dependent distribution I've ever seen of it, and now maybe it's in the lymphatics as well, but it's just quite striking. So, all right, well, Howard, I'll stop there. I'll let you show a few here.
Okay. Okay. This continues a theme that David really started, and since he started showing us these paralysis cases and to look at the crus, I've been paying more attention to that. And we've shown a number of these recently, and sure enough, I came across another really nice example of that. So the context in this patient is itself quite interesting. This is a patient with myasthenia gravis. And sure enough, there is the finding very typical of a thymoma. You get a feel for its location and its proximity to left phrenic nerve. So the patient had surgery to remove that. So now I'll bring in the chest radiograph before the surgery and a more recent one. And of course, this shows findings very consistent with phrenic nerve injury. Presumably, the nerve was sacrificed during the surgical procedure. So on that frontal projection there, and the corresponding lateral projection where we see the whole diaphragm is up, that's posterior costophrenic sulcus is way up in relation to the opposite side, very consistent with that. So of course, I'm now going to show you the crus so we can look at the comparison there. So let me bring up just the standards alongside each other and see if this will scroll separately. So let's go back to before surgery around about here, and more recently there is the crus on the right side, and sure enough, looking for the one on the left, it's very, very small, really hard to see. So
it's almost non-existent.
Yeah, really. Yeah, it's non-existent. Just scrolling back and forth where it should be, comparing it to its companion, it really is very thin. So another super nice example of that phenomenon. Of course, the whole diaphragm is thin. One can see it. And you can see it here, going down to there, where the crus should be. Just super thin, inconspicuous. Yeah. So another really nice example of that phenomenon.
Absolutely.
Yeah, now that I'm learning to look for that when I see a case like this.
The crus is crucial.
Yeah, learning that. This is a nice teaching case for residents in particular. You know, there's a differential diagnosis for that, but there is the young person with the frontal and lateral, and clearly we have extensive abnormality related to the anterior mediastinum in particular, very consistent with mediastinal mass, massive lymph node enlargement in that portion of the chest. And of course, I think the first thing one should say is Hodgkin's lymphoma in a young person as a likely diagnosis for that. And here you'll see the extent of the abnormality. What's notable here is the central venous obstruction associated with it. So there's a lot of abnormality. Looking for the SVC and the usual things. We don't see that, but we see collateral vessels going every which way. So the usual pathways are involved, but one pathway which we've shown before that is involved here involves the left pulmonary vein. So as I scroll through here, you'll get to the point just about here where we see those systemic vessels and those pleurohilar vessels spurt into the vein right now, right there. And that vein lights up quite nicely. So those two images right there and there shows a collateral emptying into that pulmonary vein. And we've seen that before. This is a really nice example of that phenomenon. Of course, it's a nice example of the superior intercostal vein, a nice example of pericardiophonic vein, nice example of periphrenic veins crossing the midline, heading towards the inferior vena cava, and all the other pathways. But, and all these really big superficial veins there.
How about the bones? Do you see any of those little, those sclerotic fake outs that we've seen recently? Because it looks like there are some intervertebral.
Paravertebrals and intervertebrals in the usual way, rather than the intravertebral ones, right? It's
But Howard, that's interesting, because usually the shunts that we see when you have collateralization into the pulmonary veins, I always think of it, and I think most of the cases we've shown, at least you and I, have been in more long-standing SVC syndrome, like end-stage renal disease patients. But presumably this is more of a, not acute, but maybe subacute as this mass has enlarged.
Yeah.
So.
Yeah. Yeah. Yeah, right there. There's a nice, that image is really nice. Yeah, presumably she's young and she's got Hodgkin's, but definitely has that pathway right there, just by random chance. So a really nice teaching case from several points of view, both for the mediastinum, Hodgkin's, as well as collateral pathways, and then that little right to left shunt that we sometimes.
Howard, the other point that this helps make in relation to the previous case with the thymoma is if you follow this pericardiophrenic vein up to the level where that previous person had the thymoma, you can see exactly where the phrenic nerve is, because it's along with that vein that's lit up here. So the phrenic nerve travels with the pericardiophrenic artery and vein.
In close proximity to this guy.
So that corresponds exactly to where you showed the tumor before that they resected in the previous case.
Yeah.
That's why the phrenic nerve was at risk.
Yeah. Good.
So is there normally a right-sided pericardiophrenec vein that also would parallel the right phrenic nerve?
Yes, and it ends up, as it gets near the diaphragm, it ends up lateral to the inferior vena cava. So you can track it down on the right side as well.
Yeah.
I didn't know that. That's good to know.
Yeah. Oh, by the way, look at this tumor really going into the chest wall. So now I'm reminded, I think when she presented, she actually presented with, I don't know why this does that so much. Let me see if I can make that smaller. But I think she presented with, she started to feel the mass on the right side of her chest. Yeah.
Gross.
Yeah, it's not nice. And sure enough, she's undoubtedly feeling this too. Oh, let's have a look at the bone here and see if it's... Oh, look, there is some remodeling, isn't there?
Yeah. There's
of that bone, of the sternum, like right there.
Periosteal reaction.
Yeah, right there. Exactly. So it's been there a while. Yeah. Okay. This one is a particularly nice example of this. So it turns out we have a surgeon here that is starting to do more of these operations. So I get the opportunity for really nice rad path kind of correlation. So this is a young person and this is a nice teaching radiograph, obviously, of pulmonary hypertension. And in the absence of distended pulmonary veins and other things, one can conclude pulmonary arterial hypertension, and then have the discussion about causes of pulmonary arterial hypertension. So now I'll show you let me just skip the first CT just for a moment. Here is a lung perfusion scan, and obviously there are many segmental perfusion abnormalities, particularly in the lower lobes that you can see there. And let me bring up the axial CT here and get the window just right. First, let me actually go to the lung window. So this one's relatively subtle. Well, maybe not so subtle as I remember, but look for mosaic attenuation, and we begin to see it here. So there are areas of relatively hypoattenuating lung compared to here. And then as I scroll down, you'll see that becomes really conspicuous in the lower lung zone. So down here, this whole area is really much blacker than it should be. So there is mosaic attenuation. And particularly in the lower lobes, even without looking at the mediastinal windows, the observation is these vessels here, some of which of course are arteries, are too small. So that's a conspicuous finding. Now let me switch over to the vessels. Of course, we'll have a dilated right atrium and right ventricle. But in looking for central clot in the big vessels, left and right, so far we don't see it. We don't see it there. But just look how dramatically these vessels narrow up. So there's a huge difference between the caliber of these arteries and then these here. So these really reduced remarkably in caliber. There's a bit of motion and sharpness there, but these vessels are very abnormal, very narrowed, and irregularly narrowed. So it's really lower lobe, but mostly the proximal segmental arteries of the lower lobes substantially abnormal. So certainly this is consistent with CTEPH, but the abnormality is in these lower lung vessels in particular. So now I'll show you what came out of those vessels. And these are the material that came out, quite a lot. And these came out of these lower lobe vessels in particular, more on the left than the right. And what's really nice is the follow-up CT. If you had sort of the question, how much are these vessels going to open up once they've taken out stuff from them? Let me show you that. So let me unsync that just for a moment. So these are what they kind of look like here, how skimpy and narrow they are on the left side. And then look over here how nicely those vessels are opened up after the endarterectomy. Now they look much bigger and perfusing really nicely. And I was really impressed by that, looking at these vessels compared to these over here. So a lot of stuff was taken out and they're perfusing really nicely. I was really impressed by that.
How about the mosaic?
Yeah, so scrolling through this lung, it's kind of relatively unimpressive now, isn't it? Relatively speaking.
Wow.
Isn't that an interesting correlation? Yeah, compared to what it used to look like there.
And also, Howard, I was thinking when you're showing the first CT, and you can see in those lower lobes how you have a little bit of bronchial dilatation in the areas of mosaic perfusion, which is a well-described finding in
Like
chronic thromboembolic disease. Yeah.
Yeah.
And that looks like it's gotten better too.
Yeah.
But it's the bronchiectasis or bronchial dilatation is one of those things I always read about, but never really understood why it happens in chronic thromboembolic disease.
Yeah.
But I mean, it's well described, and it's also a reason, a potential pitfall is if people see that and then just attribute the mosaic perfusion to small airways disease, assuming that it's related.
Yeah.
But I have no idea why that would get better. But I guess I don't know why it happens in the first place.
I don't know.
So.
Oh, I forgot to show you this nice image with great correlation between the perfusion SPECT CT in the lower lungs and in this image there. And let's see what the surgeon said about this. So let me just bring that up again. There's some of the preoperative imaging. She's got pulmonary hypertension, quite severe, of course. And I'll have to try and figure out why this happens with these PDFs. Nice specimen, especially in the left lower lobe. Pressures were in the low 30s from the low 50s during the surgery. So unusual, such a young person to get this this thing. She's only 30 or so, but there's the history right there that I got.
So what if she was on birth control pills, or she must have had a coagulation workup and all of that?
I don't know. Yeah. Yeah, I think she's 30.
Very impressive. Howard, that's the first time I've seen this CT follow-up, and the regression of all the findings is just remarkable.
Yeah, that's a really nice example, isn't it? Yeah. Yeah. All right.
It looks her right ventricular distension also decreased. And
yeah, those chambers are smaller. Yeah, a bit smaller. Yeah, that's impressive.
I wonder if she'll still have her tricuspid insufficiency, though, because that annulus might have stretched out.
Yeah. All right, I showed you the really neat cases. Well, I'll show you this one too. We've shown many examples of this before, but it's the case of the consolidation that isn't pneumonia. So I think the history here is of persistent opacities initially diagnosed, and we've seen so many examples before as pneumonia that isn't pneumonia. And of course, this is an adenocarcinoma. In terms of teaching, it shows all those features. So we have a combination of nodules, some solid nodules. We have ground glass. We have a mixture of ground glass and consolidation. Here's a nodule that has cavitation or pseudocavitation. Here's an area within the right lower lobe, down here, in which presumably there are areas of so-called pseudocavitation that may occur in this form of adenocarcinoma right there. So this has all the features that the textbooks talk about in diffuse adenocarcinoma. And this one turns out to be on pathology a mucinous adenocarcinoma. And this is one of the situations, and I didn't know this, but sometimes the mucinous variety doesn't have the TTF1, which is usually, of course, the case with adenocarcinoma. But this one was TTF1 negative. And I saw that comment from the pathologist. So findings very consistent with diffuse invasive mucinous adenocarcinoma. Of course, I don't know whether the patient actually has, say, bronchorrhea, but I wouldn't be surprised if she had some, but otherwise has many of the features. Here, there's almost a reverse halo sign. Shame. But a nice example of that.
Yeah.
Well, Miles will show another one. So this is a really classic case of alveolar proteinosis. So here's a radiograph at time X, bilateral, patchy, but extensive consolidation. That goes back to last year. Here, presumably, we have a time when the patient has an exacerbation of it. So extensive bilateral, patchy, multilobar consolidation. This is what the CT2 looks like. As you might expect, we're going to see ground glass consolidation, combinations thereof, and perhaps even in the right middle lobe area, some, down here, some crazy paving. So findings very consistent and pretty typical, almost typical for alveolar proteinosis. It isn't always super symmetric, but otherwise very consistent with primary alveolar proteinosis in this person.
Treated with lavage, or?
Yeah, he has had episodes of lavage, yep. Yeah, I think. I'm not sure when the last one was. I wonder if he did have a lavage after this. And I think I said up here he does have GM CSF antibody positive, which is that classic association now with primary alveolar proteinosis. All right, this other pacemaker one I'm going to show a later time because I have another nice example of the one that you showed a couple of weeks ago, David. They're starting to do them here, so I have one or two examples of my own. I can show one bigger picture of it, show the tines right there.
Mm-hmm.
Here they seem to have a point in time when I play this that they're in that ventricular cavity, and I guess somewhere they inject some contrast. They make sure that they're up against the ventricular wall just before they deploy the guy. And then this is after deployment, and the tines are appropriately. Now, there is another image of a case that I'll show next time because I have to get that into my teaching file, but there is a point where they do a pull test of this thing. So once they have it in position, they pull on it, they tug on it a bit to make sure that it's affixed to the wall. And when you do that, and it is fixed, these tines that you have there kind of stretch out momentarily as you pull on it, and then you release it, and it goes back to this. So they can do a pull and something test to make sure that enough of these tines have engaged into the ventricular wall. So when I get that one, I'll show that one on another occasion because I saw one the other day.
So Howard, are the tines pointing straight ahead in the pre-deployment phase? So on your movie, were they initially pointing forward? Can you tell?
Let's see.
Yeah, it looks as if they're in that.
Well,
yeah, it looks as if they're ahead of the device, ahead of the little dark nipple, and they're in a sleeve, and they're probably pointing forward. And then when they release them, they're pushed into the muscle, and then they hook around into that curved back
like that.
anchored configuration.
Yeah,
You're probably right.
Yeah, here's a picture of a graphic of doing that. That pull test. I think you're right about that. So here you can see if they're engaged, they strip up like that. when they attach that device and pull on it.
Cute.
And I think I have an image on another patient when they were doing exactly what this diagram shows, and I'm going to try and find that to see what the tines look like when they do that. Of course, they may not, after they do a bunch of these, they may not start saving all the fluoro images, but I had one the other day. I'm going to take a look at some more and see if I can perceive this so-called pull and hold that they do.
The manufacturer's website had a video, a cartoon of the deployment of these.
I'll see if I can find that too and show that.
Mm-hmm.
All right, I think we've shown good cases this week. We'll quit and gather together next time.
Thanks, guys.
Thank you very much, guys.
Thanks, everyone.
Have a good weekend.
Travis, have a good week. Bye, everyone.
Talk to you later.
Bye.
Thank you.